Yeah, I think, madam, we are simultaneously live on YouTube. Okay, so we can start.
So hi, good afternoon. I have been given instructions not to waste much time on introduction, but again, I would like to welcome you to this session on luteinized unruptured follicle as a continuation of the topic on trigger, as we received a lot of requests to touch upon this topic and to have clarity on how to go about it. So I welcome Dr. Jay for this session. Yeah, Dr. Jay, you can take over.
Yeah. I will just give a very brief outline of luteinized unruptured follicles. Okay. First of all, kindly don't hype the syndrome of LUF. Okay. It really doesn't deserve any attention or any hype. That is something which is very important. It just sounds beautiful, but there is nothing major which people should keep in mind as far as that is concerned. If you ever study the definition of LUF, no, the definition is beautiful. It says that when there is a LH surge and after a proper LH surge, there is absence of ovulation, okay, and it converts into a luteinized follicle. That means it forms a abnormal corpus luteum because the ovulation has not occurred. All right, that is what you call to be a luteinized unruptured follicle. Okay. For you to classify or put anything as LUF, just remember one thing: everything else has to be normal. That means, see, as fertility specialists, we tend to expand our horizons by giving induction, ovulation, induction in every case. We will have ovary stuck to the esophagus, we will still go and induce that ovary. We will have ovary which is with endometriosis, we will still go and do ovulation induction in that. We will have ovary post oophorytis having adhesions in the pelvis, we will still go and do ovulation induction in that. In all that situation, there is a pelvic pre-existent pathology. Okay. And whenever you have any form of pre-existent pelvic pathology, this could be in the form of any inflammation, it could be tuberculosis, oophorytis, endometriosis. In all these situations, you are exposing your patient to a higher risk of luteinized unruptured follicles, because the characteristic features which are needed to ovulate, okay, are governed by two things. They are, one, governed by the quality of oocyte which is present inside that follicle, and second, they are governed by the theca cell factors. That means they are then governed by the stroma of the ovary. And it is actually the stroma of the ovary which comes in contact with the peritoneum, with the inflammatory substances, with the rectum, with whatever it comes in contact with. Okay. So if there is an abnormality there, you have a predisposed risk of having a luteinized unruptured follicle. Okay. There will be certain occasions where you will have an LUF despite these pathology not being present. That means there is no endometriosis, no pelvic inflammation, no TB, no oophorytis, no adhesions, nothing like that. And you can still have an LUF. Of course, you can still have an LUF. And in that particular situation, the most important problem is not the patient, it is the doctor. Okay. It then boils down to the type of HCG which was used. What was the temperature sensitivity of that HCG when it was used? And what was the size of the follicle at which the trigger was given? All right. So now I will shift to the whiteboard and try and put this up in a simple whiteboard format. So Shilpa madam, please stay on this thing, unmute. And I have started the sharing of the screen. So I hope it is visible, right?
Yeah.
Okay, so we are trying to deal with luteinized unruptured follicles. See, when I look at the ovary and when I draw an impending follicle, a follicle which is about to rupture, okay, what is going to happen in that is there is going to be a lot of prostaglandins which are going to be released. There is going to be hypervascularity, and there are many proteases which are going to be released. All of them cause lysis here. Okay, all these things cause lysis here. Okay, now because all of these things cause lysis, the presence of this lysis allows the oocyte which is present inside, okay, which is present here. Let me just change the color for this oocyte. The oocyte which is present somewhere here inside, it allows this oocyte with this lytic activity to then come out. All right. One characteristic thing which is mentioned in most of the textbooks is that, array, prostaglandins. So what would have happened is you had an LUF because you took NSAIDs. So that means patient was having fever and you gave patient paracetamol. Patient was having fever, you gave patient ibuprofen. Okay. In all this situation, what happened is because of that, the follicle did not rupture. Okay, guys. Just remember, you can probably try to use these drugs one of rare occasions where you have missed out on something to prevent that rupture, but otherwise a dosage of these drugs is not going to be something which is going to cause an LUF in all occasions. All right, now please remember that. Otherwise we will stop using antagonist and all these things, and we will start using prostaglandins as a part of control for LH surge. So kindly don't get into that type of logic in the head. That is all theory textbook knowledge. All right. Simultaneously, there are going to be a bunch of individuals who are going to join this session and who are going to say, you have prostaglandins which are present. So how do we increase the prostaglandins? Which is, I have read a latest paper in fertility and sterility which says GCSF can be used. So we had written a response to that letter. So 3 things have been mentioned. You are supposed to give 100 micrograms of that, and you are going to give it a day before. All right. You are going to give it 1 day before, and you should give it when there is you should avoid giving it when WBCs is more than 10,000. Now this is definitely not an Indian criteria. I think we use GCSF very extensively when we are doing our stem cell programs. Okay, so please remember what is the Indian criteria for this. First of all, the dosage which is available is 300 microgram. Okay, second, it has to be given at least 3 days prior. Okay, and third, for Indian women, keep a cutoff of 4,000. Okay, if it is less than 4,000, maybe then GCSF has some role in treating LUF. Otherwise, kindly do not read one Chinese paper and start stating that, acha, now a Chinese guy has given LUF. I have a vast experience of 2 patients where I have given GCSF and I have got excellent outcomes. Kindly don't do any such type of things. Okay, please. The most important thing which people should take home from this lecture is that whenever you are doing this and you have a pre-existent pathology, okay, and you have had 1 cycle with LUF, okay, so kindly treat that pre-existent pathology first. So what we do here is that the minute a patient is referred with LUF, we have a lot of referrals for LUF actually. So the first thing which we do is we ensure if there is any pre-existent pathology or not. If there is a pre-existent pathology, then the treatment of choice is to do a laparoscopic correction of anatomy. Okay. That is very, very important take home point. You have to laparoscopically correct whatever problem there is, if it is correctable. And if it is a correctable problem, then your LUF will any which ways go away. Okay. Second, can be a situation where there is a no pathology. That means you can't really find out anything. There is no pathology. In that situation, it is very, very important to use HCG 10,000 international units at 17 to 18 millimeter size of follicle. See, commonly what people do is that, let's try and be very honest, the follicle diameter which is measured by your radiologist. I know countless people, at least in the city of Mumbai, who don't do their folliculometry. They send it to a radiologist, and the radiologist will suddenly start reporting things like 13 millimeter. Next day it is 15 millimeter. Then it is 19 millimeter. So you say 19 or ek din, and you make it 21 millimeter. Whereas instead of 21, it is actually 24 millimeter. All right. And this 24 millimeter pe jaake you will give an HCG 10,000. And then you will complain that I had an LUF, in the previous cycle, very bad response. I want to change the brand of HCG. You should not be changing the brand of HCG. You should be changing the brand of your folliculometry sonologist. You should be doing the sonology on your own. When you do that and when you assess this, remember, when you remember this as a tagline, 80 to 90% of the LUF is going to get sorted any which ways. All right. Any which ways it is going to get sorted. There are going to be people who are going to say, no, all factors for the patient were absolutely normal. I still had LUF continuously for 2 to 3 cycles. Okay, if that is the thing, then kindly do a diagnostic laparoscopy. Okay, in laparoscopy also, if you find nothing and okay, you want to counsel the patient कि यार अंदर से कुछ भी नहीं है, then the treatment of choice for the patient is to do IVF. Even in IVF, remember to give HCG at 17 to 18 millimeters or just use a dual trigger at 17 to 18 millimeters. Kindly don't act very wise and start doing IUI with GnRH agonist trigger, because one paper has shown that when you give GnRH agonist trigger in IUI for a previous LUF, okay, then it will cure the LUF. It will cure the LUF definitely, but the patient will not become pregnant. The reason why it cures the LUF is because by the time you call the patient back to you, it has already undergone luteolysis. Okay, so you are going to find that, oh my God, what a beautiful outcome. There is no LUF at all. There is no LUF because that has undergone luteolysis, and the patient will any which ways not become pregnant. Okay, so kindly don't extrapolate to those type of therapies in these type of very basic situations. Okay, please also remember that these type of theories which we try to say for luteinized unruptured follicles are really unclear to a lot of people. Okay, these are not the theories which everybody agrees. For all these purposes, GCSF was never being used for ovulation induction, especially in LUF. Understanding? It was never being used, never ever being used. Okay, it is a fluke in which they have found out that this was there. I have actually spoken to that author. Okay, he is a Chinese author, nice guy. I have spoken to him that, you know, how you came across this idea of using GCSF. So, you know, their thing was, who told them out of all people? This thing was told to them by their medical oncology department. Okay, patient is complaining of pain abdomen, you know, post chemotherapy, God knows why it must be happening. We gave some GCSF, ovulation should not have occurred. Why is there a retention cyst inside? Usme se they applied their head, okay, and they've declared that GCSF has promising results. Now, just because they've had promising results, it really doesn't apply to Indian women at all. In my opinion, 100 microgram dose is not even available in India. Okay, the standard preparation of Xgraft which is available is 300 micrograms. Okay, so you must administer 300 micrograms 3 days before. In one day, it will not even go to the bone marrow. Okay, and usually, otherwise, Indian women in their own inherent body have a good amount of PID. Okay, our women are different than Chinese women. In Chinese women, there is no PID. Okay, in Indian women, there is a lot of PID. So any which ways inflammatory factors in Indian women are super high. As a result of which, our birth rate is much higher than Chinese people. Understanding? Because no matter what, people will ovulate in India. So don't try to extrapolate those findings to these findings. That is for sure. Okay. But yes, keep the HCG in a proper cold chain. Ensure that the folliculometry is done by you. Okay. And just in case you have had a previous episode, then ensure that you trigger this patient. Just yesterday we spoke about trigger. Ensure that you trigger this patient at 17 to 18 millimeters. And please remember, in any pre-existent pelvic pathology, okay, you are going to find LUFs somewhere or the other. Okay, so just keep that in mind. And I hope, I hope it helps all of you in understanding this small topic. Don't make a big fuss about it. Okay, it is good for only such small sessions. I hope people don't really have more than 1 or 2 cases of LUF in their entire year. Okay, because otherwise, when you are going to be doing IVF, you will not even know if there was an LUF inside that. Because immediately when the patient comes to you and if there is a bulky ovary, you will start the patient on OCPs. Okay, everybody does that. So you will never understand that was there LUF or not. You are worried about LUF only in your natural cycles or in your IUI cycles and not apart from that. Okay, so I hope this lecture made some sense to all of you, and I can answer 2-3 questions from Shilpa madam.
Yeah, see, so how do you confirm it? I mean, previously they would take that peritoneal fluid and assess the hormone levels and all that in 1980s, 1970s. But now, I mean, ultrasound, I think, is the standard. Wherein
it's just ultrasound.
Yeah. So do you do the scan to check evidence of rupture routinely for these women come for ovulation induction? So then where do you diagnose them? I mean, in which cases is it like in IUI? Do you do IUI only after the rupture, or is it like you just do the IUI based on the timing?
So honestly, there is absolutely no role to check for rupture. Trust me. Okay, when you are checking for rupture, there are so many evidences of rupture. The follicle could be slightly irregular. Some follicle would form a late corpus luteum than what you want it to form. Understanding all these things are common. Honestly speaking, in all IUI cycles also, irrespective of what people talk in lectures, everybody gives luteal phase support. I'm yet to see an IUI protocol in 10 years of my limited experience and career where no luteal phase support was provided because some author mentioned that after letrozole don't give luteal phase support. Come on, everybody gives dufastol. Okay, so what typically happens is, if ovulation has occurred, you have played your part. If ovulation has not occurred, in the next cycle it will appear to you as that retention cyst sometimes, because half the absorption would have happened, or you would see it as a functional cyst 3 centimeters when the patient has come back to you on day 2, day 3. But yes, what referrals we get is when people are documenting that rupture, no free fluid in POD, features suggestive of LUF.
Okay. Yeah.
Okay.
So the next question is, we see this kind of cysts very commonly in poor ovarian reserve when the AMH is low. They come with
very common
on day 2, day 3. So this is related to, as you said yesterday, with regard to the inherent quality of the oocyte, and the whole follicle is defective. So
correct.
Yeah. So in these cases, you just kind of go ahead with the next cycle, hoping that in that cycle there would be a good oocyte, or you would abandon the cycle.
Or if you are fussy like me, do estrogen on day 2, day 3. If the level of serum estrogen is less than 50-60, okay, you can start the patient on stimulation and aspirate that cyst out. Dekho, when the patient comes back to you, and if they see that 3 centimeter cyst has become 3.6 centimeters, it is any which way is going to become 3.6 centimeters because of the inherent estrogen which will be produced in the body. Understanding? Better is to not give that patient that option only of thinking. Just aspirate that cyst out and start your stimulation. If you are really wanting to be like that, super cop types, then no problem. Aspirate the cyst and give 1 day of double dose antagonist, right? It will cause severe luteolysis. Okay.
Okay. So
and then start stimulation.
Yes. So now I think the main thing is to maintain the cold chain of HCG. And what about changing the stimulation protocol in the subsequent cycle, which would help in preventing the LUF?
I think the standard stimulation which everybody is following is letrozole. Yes. If they are not, then they must switch to letrozole, because no matter, even if you are married to the owner of clomiphene, everybody knows that letrozole works better than clomiphene. Okay. Again, I'm telling this, I'm yet to see these patients where isolated clomiphene-induced IUI cycles were done in a good IVF center. Okay, trust me. Almost everybody has shifted to letrozole plus HMG, or letrozole alone, or extended letrozole, or some such combination. Very rarely we find that patient has been given clomiphene alone, and then something like this has happened to the patient.
Yeah. So in the folliculometry, you think, like you said yesterday, the Doppler adds value as to when to give the trigger, and can you prevent LUF based on the Dopplers? Not really.
Dr. Shilpa, I lost your voice.
I'm sorry. So folliculometry, you said, everyone should start doing their own folliculometry. So in that, do you think Doppler adds any value to this LUF?
It really depends on how good you are at measuring Doppler and from where you are measuring the Doppler. A lot of people don't understand this, that Doppler, I am measuring at a particular vessel and you are measuring at a different vessel. Okay. And both the Doppler outcomes could be different. So see, when you are generalizing it for your assistants, or for when you are going to have 40-50 follicle scans in a day, you are not going to sit down and measure the Doppler parameter for every lead follicle, right? Yeah. Every follicle more than 17-18 millimeters, just put a Doppler, put the PRF to less than 3. And if there is a Doppler flow evident on magnification at 3 walls out of the 4, simple, okay, that means that it is a good enough follicle. Okay, you can't really predict that, okay, this will not form LUF. You can't do that. Okay, but you can at least tell the patient that, yeah, the flow looks to be good. Okay, You can't really end up mapping it if it is 12 centimeter per second, 16 or 20 or whatever. It doesn't really matter. To the patient, what matters is, did she become pregnant or not? Okay. So I personally don't go into the depth of peak systolic velocity every time I put the Doppler. And my standing instruction to the team is just see if there is Doppler flow at 2 or 3 walls. And if that much is present, that is more than enough.
Okay. Yeah. I think, yeah, that's about it. Any more questions? We can take it on WhatsApp groups and answer it.
Yeah. I think that is enough for LUF. As I said, the most important thing in LUF, as I've mentioned again and again and again, is if there is a previous pelvic pathology, 100% you have done something wrong. You are talking of an isolated LUF in a normal pelvis. And that is when you probably need to, give your HCG trigger at 17 millimeters instead of 19 millimeters. Okay. But otherwise, if there is endometriosis, let's assume, and you are saying I had an LUF in endometriosis, it is your mistake. Listen, the patient is going to shift. ASHRAE guidelines are not going to come to save you at that point in time. The patient will say that my doctor gave me incorrect treatment. I have developed a cyst after that. 100% when they develop a cyst, they will take 2 opinions. Okay, why did I develop the cyst after my treatment? My friend told me this cyst can be cancer. Okay. So if you want to avoid all that shit in life, okay, it's simple. Don't go by this. Endometriosis was present in both the ovaries, 2.2 by 1.8 by 1.9 by 1.6 centimeter, and opposite ovary was 3.1 by 1.4 by 2.3. So according to ASHRAE guidelines, if it is less than 3.4 centimeter, which ASHRAE person is going to come and even pick up your phone, man? Okay, in such situation. Okay, please correct the pelvic pathology. The take-home point is there. Correct the pelvic pathology and then do whatever stimulation you want. Okay.
Yeah. So thank you very much. I think it was